common. Femoral neck fractures are quite common. Fracture of the trochanter is also common. And fracture of the subtrochanteric region of the femur, they are also not uncommon. So these three types of fractures, fracture of the neck of the femur, fracture of the trochanter, and subtrochanteric fractures, they will be considered together in hip fractures. Of course, it should include the fracture of the femoral head, which is uncommon. I am not discussing because this is quite uncommon and it is unlikely you will have any question about this thing. Clinically, these three types of fractures will present in the same way. Clinically, they will present in the same way. Now, क्या आज से घंटा है? আর কি আছে? DJF ZXGVQS7Q is a difficult name. Who is the student? Anybody there? Is it Jannatul Firdaus? Jannatul Firdaus, are you there? 18 Jannatul Firdaus. Well, it's interesting. I find many people, but you're not responding. Now, anybody, what is the clinical feature of this hip fracture? Can you tell anybody?
Sir, history of trauma thakbe, pain and history thakbe, unable to walk. Then, history sir, limbs are abducted, externally rotated and shortened.
Yes. The present, there will be history of trauma and the patient will be unable to stand or walk, and pain in the hip region. Okay, with these complaints, he or she will come to the hospital or to the doctor, and the signs you find. Tell me signs, what will be the signs?
Sir, movement restricted.
Yes, first the posture, the position of the limb.
This
when the patient comes to you in a trolley, you will find that the affected limb where the pain is externally rotated, maybe shortened. Now this shortening will be very prominent in subtrochanteric fracture. It may be prominent or slightly apparent in the trochanteric fracture. It will not be apparent in a hip fracture neck of the femur. But in the same way, the fracture neck of the femur, the external rotation will be slight in comparison to the normal limb, and it will be more in the trochanteric fracture, and in the subtrochanteric it will be gross. So the history is same. So together we consider these things: a history of trauma, which can be a low impact injury, it can be a high impact injury. A high impact injury is a road traffic accident in a very speeding car. A low impact injury, an elderly lady falls down in the bathroom after sleeping. Now, after sleep, she finds that she cannot stand or she cannot walk. This is a low impact injury. So it can be low impact injury or high impact injury. Let's see. So hip fractures. These are the fractures of neck of the femur, fracture of the trochanteric region, and subtrochanteric fracture. Okay. And it is the commonest site of fracture in elderly, 7th and 8th decade, in their 7th and 8th decade. And naturally, you can very easily understand it is common in the postmenopausal women. and with some comorbid conditions like diabetes and any chronic debilitating disease where there is nutritional deficit. And the cause is the weak muscles and poor balance, which is common in the elderly people. And it can be high impact or low impact. Oh, sorry. Now, we can classify the fracture neck of the femur. Well, it is a bit detailed, but if you do good in your viva examination, in a viva voce, and then the oral examination, the orthopedic surgeon may be interested to ask you the question, what are the types of fracture neck of the femur? So you can say, well, it will be classified in grossly according to the anatomical position. It can be subcapital, it can be transcervical or basicervical, or clinically it is more important. You can say whether it is intracapsular or extracapsular. So these first two varieties, subcapital and transcervical, they will be intracapsular within the capsule of hip joint, and basicervical is outside the capsule. The importance is that when there is intracapsular fracture, the vascularity is compromised and the outcome is bad, particularly if it is displaced. And in the basicervical, the outcome is better. There are other classifications, not important. According to the line of fracture, if the angle is low, you can understand it will be more stable, and if the angle is more 70 degree or more, it will become very unstable. And there are other classifications according to Gardner's classification. I'm not going to the details. Well, to see, but the important is that to see whether there is a displacement. It can be undisplaced fracture. It can be complete fracture or incomplete fracture. Incomplete fracture usually undisplaced. It can be a complete fracture with impactation. There is slight change in the angulation, slight change, but it is impacted. With the impacted fracture, sometimes a patient can walk a bit. He or she will say that I feel pain, but I can walk. I can go to the bathroom. But don't be, misguided, because still there can be a fracture because it is an impacted fracture, and you need to do something surgically for an impacted fracture. If it is undisplaced fracture, let's see, and it is impacted fracture, and it is a fracture with displacement. If it is displaced, it is very bad, particularly for the elderly people. So I already discussed about the mechanism of injury, low energy and high energy. And clinical features, the same thing for the three groups, but the displacement and deformity will be less in the fracture neck of the femur. Now, radiology, it is important. What do you ask? You ask for an anteroposterior view of the pelvis with proximal femurs. Don't go for any lateral view because it is painful. When you need to place the patient in an X-ray table for a lateral view, you need to rotate the hip, and that will induce much pain. Just take advice an anteroposterior view of the pelvis. With proximal femurs, you can detect with that X-ray any fracture neck of the femur, any fracture trochanter of the femur, or subtrochanteric fracture, and a degree of displacement. That will be enough. Now, how do you treat? Let's see how many of you are there participants. Only 9. That is very unfortunate. The students are thinking that I am not very, I will not be available possibly. Okay. That's unfortunate. Only 9 participants. Still, 9 is better than none. Now, the treatment objectives. You have to give comfort to the patient. And then rather you need to restore the hip function and allow rapid mobilization. Pain can be given with analgesics, and if the patient we are planning, usually we need to go for operative treatment. For temporary stabilization, we can advise a skin traction system, and that will give comfort to the patient. To restore hip function, we need to absolutely, to reduce the fracture if it is displaced, absolutely, fully, 100% reduction, and stabilize it. So you need an operation. And to allow rapid mobilization, if you have stabilized by a good operating technique, you can allow early mobilization, maybe non-weight bearing. Okay. So to fulfill the objectives in children where the fractures are uncommon, you can consider close reduction by traction and hip spica. This is the system of a traction. We call it 90-90 traction. So the hip joint is in 90 degree and the knee joint is 90 degree. And we need an elaborate system for this traction. It's a skeletal traction type. But rather we'll prefer, even in children, to go for operative treatment and fix with special type of pins. We call it nose pills, or special type of small cancerous leg screws. Okay, for children. In adults, internal fixation with multiple cancerous leg screws, that is the treatment of choice in any undisplaced fracture or any fracture which can be displaced fracture which have perfectly reduced in the operating table. Other options are sliding hip screw and for elderly people, hemiarthroplasty, particularly when there is displacement. We have talked about these things. So fracture neck of femur needs operative treatment. That is the main thing. Even in the children, you need to go for operation, and in the adults, it is essential. So this is the system of multiple screws. After reduction, you need some special device, some guide wires, and over the guide wires, you can put the screws and they will be placed perfectly. And you have to check it in the operation table, on the operating table using a C-arm. Okay. So multiple screw system. Saida, are you there, Saida?
Yes, sir. Assalamu alaikum, sir.
Wa alaikum salam. What is the implant? This one?
Sir, replacement hemiarthroplasty.
Yes, fine, very good. And we have two types of prosthesis for this purpose. It is a bipolar prosthesis, and there is another type, unipolar. Unipolar is a single piece of metallic prosthesis, head, neck together up to the shaft. In the bipolar prosthesis, there are two components: the shaft part, neck part, and there is a small inner ball, and outside the inner ball there is an outer ball. So ball within a ball. It's a bit complicated, but it gives better management for many purposes. So it's fine. It's a hemiarthroplasty with prosthesis. That's good enough. This type of bipolar prosthesis. Okay, fine. Now the complications. For hip fractures and for knee fractures and hip and knee operations, deep vein thrombosis is very common, very common. And in the cold countries, European and the people in the North America and Europe, it is mandatory that you need to give some thromboprophylaxis. Thromboprophylaxis are not that frequently practiced in our subcontinent, in Bangladesh, Nepal, or India, but still it is a good idea. to use prophylaxis, we can use enoxaparin, low molecular weight heparin, and other systems. There is another topic. And from deep vein thrombosis that can be complicated by pulmonary embolism. And for any frail patient lying in the hospital bed for a prolonged time, pneumonia, bed sores, these are important. And in fact, to prevent these deep vein thrombosis and its complication of pulmonary embolism and pneumonia and bed sores, we want to operate on any patient with fracture neck of hip fracture, so that the patient will be mobilized very early. You know, these can be prevented. All these can be prevented by early mobilization. And complication of open reduction internal fixation with screws or anything, avascular necrosis can occur and non-union can occur. These are also complications. And after hemiarthroplasty, there are the other complications can occur. We want to prevent them as far as possible. Infection can occur, dislocation of the implant can occur, loosening of the implant can occur, protrusio-acetabuly, and periprosthetic fracture. Protrusio-acetabuly, when this part of the acetabulum is very thin and it is a tight-fitting prosthesis that will erode the acetabular floor, and the head will migrate internally. So it will be protrude into the pelvis. That is protrusio-acetabuly. And periprosthetic fracture is a fracture which occurs around the shaft. Here, if there is technically there is a defective operation, then there is and particularly during the operation, when we are making space for the shaft, we can make a crack there, and later on fracture can occur around that shaft of the prosthesis. That is periprosthetic fracture. Okay. Now, these are the things about the fracture neck of the femur. Trochanteric fracture, they can be classified in various ways. The main thing is that stable or unstable. Stable or unstable. So let's just see these pictures. A fracture line running from the greater trochanter to the lesser trochanter, and no other part. It is not much displaced. Stable. Same thing with some third fragment in the lesser trochanteric region, minimally displaced, stable. Well, more fracture components, a bit displaced, well, plus minus stable, and multiple fracture, the same fracture line with multiple large components, unstable. We require open reduction and internal fixation. You have to open up the fracture site and manually you correct the displacement. Then you fix it with an implant. In the stable type, often you can reduce the fracture by close manipulation in the fracture table. I hope you know about the fracture table. Fracture table. About the people. Sanjida, are you there?
Yes, sir.
What is a fracture table? It's a special type of operating table where there is a perineal post to make the patient stable, and you can put traction to the lower limbs using the leg pieces. So these are important for management of fracture operation and non-operative for lower limbs. The fracture table. So you need a fracture table, and you can reduce the stable type of fractures if slightly displaced with just traction. So you don't need to go for a bloody operation, and after you achieve the reasonable replacement of the fracture or correction of the displacement, you can put some small incision and you can fix with implants. So that is the importance. But for unstable fractures, usually they are very much displaced, and you need to go for an open method, which is bloody, takes you need extra blood transfusion. It takes a long time and also traumatic to the patient. So these are it is a common thing. Dynamic hip screw. You can fix with dynamic hip screw. It is good for this type of stable fractures where the fracture line is running from greater trochanter to lesser trochanter. And you can see this angle is in such a way, this implant is made in such a way that they will be perpendicular to the fracture line. They will be perpendicular to the fracture line. It is called dynamic hip screw. It is called dynamic because this part of the screw can slide within this part of the barrel, and that is useful. This is the sliding mechanism. It is a plate part and a barrel part and a screw which can slide back. So when we place the thing, you first insert this screw in such a way it comes close to the subarticular bone, which is very strong bone, and it is a large caliber screw. Then we put the barrel and plate arrangement, and then we fix it with multiple screws. So this is the fracture line, and during the healing process, some absorption occurs in this fracture line. And when there is fracture line, as the patient, we encourage the patient to walk partial weight bearing, they will, impact. This is the movement of the proximal part of the bone. There is a head and neck part. So it will allow this part to back up here, and the tail of the screw will come out. The fracture will remain, the stability will be maintained, and there is no complication. If it was a fixed screw system, then when this impactation occurs, there will be cutout of this part through the head, and then that will damage the acetabulum. To avoid this damage, we can use this dynamic hip screw. So a bit complicated, but not very difficult to understand. Well, that is the dynamic hip screw. That is the standard system. There are other systems also. This is unstable type of fractures. It has been stabilized with this one. For trochanteric fracture and also for subtrochanteric fracture, this type of nail and screw system, it is good. Proximal femoral nail with screw. A bit technically difficult to use this thing, but it is very useful. There is another type. Cephalomedullary nail. It's called cephalomedullary nail. We can use special type of plates. We call it trochanteric plates. Trochanteric plates. Multiple screw in the proximal part through the trochanter and the neck, and multiple, screws in the distal part of the shaft. And you are not touching this part of the comminuted fragments. Fixed angle plates. So, well, it is not needed. It is the technical details. So, subtrochanteric fracture. A trochanteric fracture is a fracture which occurs between the lesser trochanter and the greater trochanter. A subtrochanteric fracture, it is distal to the lesser trochanter. Usually, all of them are unstable, very unstable. And you need open induction. Cephalomedullary nail is very good. And this is cephalomedullary nail. But you can use also dynamic hip screw or other types of plates and screws. You need a very long, plate, very long plate. Cephalomedullary nail. So complications like any other operation, in fact, infection, implant failure, malunion, non-union. So, what is implant failure? The implant may become loose. The implant can become fractured the implant mechanically, when it fails, we call it implant failure. These are the examples. Now, these are all about the fracture, hip fracture. Do you have questions? You can ask me. Yes, please. আমি বলছি এটা খুব বেশি ডিফারেন্স নাই, দুটাতেই একটা হিস্ট্রি থাকবে, সিমিলার হিস্ট্রি, কিন্তু তুমি ক্লিনিক্যালি এক্সামিন করার সময় ইউ উইল ফাইন্ড ডিফারেন্সেস। প্রথম কথা হচ্ছে আমি বললাম যে there will be the external rotation will be more prominent. If there is a prominent external rotation of the limb, you think about the trochanteric fracture. When there is a slight or no rotation of the, I mean, of the limb, you think about the fracture neck of the femur, particularly the impacted type of fracture. Another thing, shortening. Shortening is also possible in fracture trochanter, particularly when there is very much unstable and multiple fractures. But for a stable type of fracture, there will be no difference from a neck fracture. Well, when you examine the patient, you have to see, look, feel, and move, isn't it? When you look at the site in the proximal part of the thigh, you'll find ecchymosis, blackening. In case of trochanteric fracture, you may find, in fact, you may find, but in the fracture neck of the femur, you will never find a blackening, because it is the fracture is more deep seated, and blood will not seep out to the subcutaneous plane. So these will be the clinical differences. And if you say about the other things, the method of treatment will differ, and outcome, fracture neck of the femur is a more difficult thing and more complicated thing, with less worse outcome. Fracture trochanter can be managed well because it is much vascular and union can be achieved very well. Any other question?
Sir, আমাদের যদি ask করে যে ফ্র্যাকচারের যদি গার্ডেন টাইপ 1 এর ট্রিটমেন্ট কি, এভাবে করে কি স্যার আমাদের ask করতে পারে?
আনলাইকলি, এটা পোস্ট গ্রাজুয়েট কোশ্চেন প্রশ্ন। তুমি খুব ভালো যদি উত্তর দাও তাহলে এটা জিজ্ঞেস করতে পারে তোমাকে, তাই আমি আশা করি তুমি খুব ভালো উত্তর দেবে। গার্ডেন টাইপ 1, ঠিক আছে, ফর এনি ফ্র্যাকচার অফ দ্য নেক অফ দ্য ফিমার, কমপ্লিট অর ইনকমপ্লিট, ইউ নিড টু ফিক্স ইট। বলে স্যার আমি এটা যেহেতু আনডিসপ্লেসড ফ্র্যাকচার, আমি এটাকে ফিক্স করে দেব উইথ মাল্টিপল স্ক্রুজ, ব্যাস শেষ।
জি স্যার, থ্যাংক ইউ স্যার।
Any other? বলো। নাই, আচ্ছা ঠিক আছে, তাহলে আগামীকাল তোমাদের মুরাদ পড়াবে, বুঝছো? You'll find, yeah, I hope he will talk about fractures in general. তোমাদের এই যে এই ক্লাসগুলো এখন হচ্ছে, তোমাদের এখন না কি বলে এটা ব্লক প্লেসমেন্ট না নাকি থিওরিটিক্যালি?
জি স্যার, কিন্তু আমাদের বলছে যে খোলার পর আবার আলাদা করে ব্লক প্লেসমেন্ট দিবে।
ঠিক আছে, আসলে তোমাদের তো হাতে কলমে কিছু দেখানোর ব্যাপার আছে। আপাতত এই ক্লাসগুলো এভাবেই চলবে, তাই না? অন্য কোন ক্লাস হচ্ছে না তো? তোমার 2 দিন শনিবার রবিবার হচ্ছে মেডিসিন, তারপর নাকি?
না স্যার, শনিবার রবিবার স্যার গাইনি ক্লাস ছিল, যেটা হ্যাঁ স্যার, আর সোম আর মঙ্গলবার স্যার মেডিসিন হয়। হ্যাঁ
ঠিক আছে, আর বুধ আর বৃহস্পতিবার হবে মানে সার্জারি, তার মধ্যে অর্থোপেডিক্স পার্ট থাকবে 11টা থেকে, ঠিক আছে? এভাবেই চলুক। কিছু কিছু তোমরা বলো তো, তুমি নিজে একটু আলাপ করো, বুঝছো? You ask your friends to participate more as far as possible, কারণ এখন তো তোমাদের আস্তে আস্তে পড়াশোনাটা শেষ করতে হবে, তাই না? তোমরা যত বেশি ইন্টারাকশন হয় তত ভালো তোমাদের। মাত্র 14, only 14 প্রেজেন্ট। হ্যাঁ, একজন আবার চলে গেলে এখন। আচ্ছা, আমিও চলে যাই তাহলে, ঠিক আছে? ওকে, সি ইউ।
জি স্যার, থ্যাংক ইউ স্যার। আসসালামু আলাইকুম স্যার।
থ্যাংক ইউ।